how are we dealing with clinical guidelines in ERKNet? Well, ERKNet, as all ERNs, have the task to try and harmonize disease management by adopting existing guidelines and developing new guidelines. And we actually tackled or are tackling both tasks in our network. And what we did in the initial phase of our network activities was to review all the guidelines for rare kidney diseases that were available at the time in 2017, 2018. And we used a system called AGREE to systematically perform these reviews. The AGREE platform contains items for adjudicating the rigor of the development of the guidelines, the clarity in which they are presented, the purpose and the scope of each guideline, its applicability in terms of clinical usefulness, the editorial independence, and stakeholder involvement. So we screened the literature and found a total of 158 guideline documents in the various thematic areas of rare kidney diseases. And we pre-selected 71 of these for evaluation. We selected documents that were not outdated and seemed to have a minimal level of quality and consistency to be, in principle, eligible to be adopted by ERKNet. So on these 71 documents, we performed the AGREE evaluation, and finally we accepted 41 documents as guidelines to be endorsed and adopted in the ERKNet centers. In addition to this quality assessment, and each guideline, I should say, was evaluated by 2 to 3 experts. In addition to that assessment, we thought we should also ask our membership whether the selected guidelines were really clinically helpful or not so. So we performed an online survey on the 41 guidelines that was sent to all ERKNet members, and the relative clinical usefulness was rated on a 5-point scale from 0 to 4, from not helpful at all to extremely helpful. And that is what was the outcome of this exercise. So on average, the guidelines in the different thematic areas reached a score of 2 to 2.5, which would be between quite helpful and very helpful. But there were some outliers as well, some guidelines that had a good applicability score in the AGREE assessment and a not so good score in the user's assessment. And eventually we picked these 3, which did very poorly in both or relatively poorly in both the AGREE system and the survey, and we discarded those 3 guidelines, and we did not adopt them eventually. In the next step, we posted summaries of each of the adopted guidelines on our website. So they are now available to our members, but also to the public at large. And we included hyperlinks to each of these guidelines, but we also summarized the core recommendations for rapid orientation. And we also included some comments by the evaluators that we felt useful for readers. Once that was done, we looked at the remaining work that would have to be done. So we performed guideline gap analysis. So in each of the thematic work groups, we evaluated which diseases or disease groups for which there were no guidelines available, and then we ranked them according to priority for development of new guidelines. And each of the working groups then took the top scored topics and did a standardized guideline development plan. So the topic was selected and the population was defined. And then we found an agreement whether we would have a formal guideline or a clinical practice recommendation or just a consensus paper, depending on the available evidence. We selected writing committee members, and those committee members formulated PICO questions. We performed a systematic literature review for each of the topics, and that is actually done by the central office in Heidelberg, where we have one project manager that was trained in the German section of the Cochrane group here in Freiburg, and she is now performing all the literature reviews for the working groups, for the writing groups. And then usually we have one face-to-face meeting, several online meetings, and one face-to-face meeting per guideline that we are organizing by the network. And there the recommendations are formulated and the evidence text is drafted. And then these draft manuscripts are gone over by the group repeatedly. And once we have a final draft, this is then subjected to peer review. And we assign an external voting group from other members of the ERKNet thematic work group, but also from with members of the professional societies that are not directly related to ERKNet, to get also an external view on the guideline statements. And that leads to a kind of Delphi consensus finding process. And at the end, we arrive at a final publication. So that's how we do it. And yeah, I already said we have these one-day multi-stakeholder workshops, collaborate with the renal medical societies. And the money required for that whole process per guideline is about 10,000 euros for the workshop and the manpower that's required for the evidence review. So it's a relatively modest cost, I would say. And by now, we have published around 10 guidelines in quite good international journals on the various fields of rare kidney diseases. You can see here also the collaborations we had with the different professional societies. And another 10 guidelines are currently under production. And I plotted here the number of guidelines among the endorsed and the developed guidelines per year of release. And you can see that we have a few endorsed guidelines which are quite outdated now and which will require to be renewed, updated. But you can also see that in the last 3 years, the new guidelines, the ERKNet guidelines, are now the first source of authoritative information in this field. So we are really becoming the machinery to produce guidelines for rare kidney diseases in the first place. So the landscape really has changed. This is the list of the 30 most common rare kidney diseases according to our registry. And the blue bars show where guidelines were already available when we started with ERKNet. And the white bars are basically the white spots on the guideline map, so to speak. And now, a few years later, we have filled quite a number of these gaps. There are still a few white spots that we are going to cover in the next few years. So we systematically provide guidance documents for all the rare kidney diseases. And we are focusing, of course, on the more common diseases in the first place. But now we are already in a phase where we can also extend our activities to less common diseases. This is the list of guideline document projects that are currently ongoing. So you see a few papers are in preparation. A few have had the evidence review completed lately. And for a few, the PICO questions are currently being performed and others are still in the planning stage. So that is what I wanted to say about guideline development. But then you have to implement the guidelines, and you also have to make sure that the reference centers adhere to the guidelines that are proposed. So how can we do that? And we gave a lot of thought to that adherence and implementation issue. And we came up with a system that allows us to monitor the guideline adherence and guideline implementation through our ERN-wide registry. So for that, we defined key performance and outcome indicators, which include guideline adherence indicators. They include guideline statements. And we first had proposals by our experts for candidate criteria for these indicators, which were then evaluated independently for their validity, reliability, feasibility, relevance, and eventually priority. And we performed an initial ranking that was then discussed and led to a final ranking. So here you see this was also a score from 1 to 5. And you see the mean values for these different criteria. And what we also calculated was a so-called feasibility priority product, which gives us an indication of indicators which are both very important, but also clinically very feasible to pick up from the electronic health records and the files. So we have decided on a number of these. I think by now it's about 56 across the different thematic areas. And in our registry, which is now very well established and to which most of the ERKNet sites are actively participating and contributing patients. We have now more than 16,000, by now it's 17,000 patients in this registry. And in this registry, we have what we call the KPI monitoring tool. It's a kind of statistical module that you can click, that you can call up on the website. And it gives you instantaneous statistics. So as soon as data entries are updated in the registry, the system will calculate certain, it will calculate the means and the percentages for each of these key performance indicators. Like what percentage of patients have systolic blood pressure below the 75th percentile, which is one of the targets for children with chronic kidney disease. And you see here that the center has 28% of patients with a blood pressure below the 75th percentile. Ideally, it should be 75%, right? If the blood pressure had a normal distribution in this diseased population. So we're not fulfilling this target, but we can compare this center also to all ERKNet centers, to the overall community. And you can see that 32% is the overall average of 760 children with chronic kidney disease, stage 3 to 5, that are looked at here. So, so the center is doing comparably well as all the other centers. So in this way, they can compare themselves, their own performance regarding all these recommended treatment targets. They can compare their own center with the ERKNet community. And in this way, we are trying to stimulate and encourage the sites to adhere to these guideline targets, and we create a kind of friendly competition between the centers sometimes in improving the performance of treatment. We make sure that the information goes out to all the doctors in the units by releasing every 6 months this semi-annual report, which is basically this, the summary of all these statistics by center. And so every active physician in the network receives these indicator monitoring reports. So what does that mean in clinical practice? Here I have an example of the 2016 guidelines of the European Society for Hypertension, where it is said that children with chronic kidney disease without proteinuria should have a blood pressure below the 75th, and with proteinuria they should have a blood pressure in the low normal range below the 50th percentile for age and height. And as I just showed you, these are the values that are achieved in the registry. So you have a direct comparison. Another example is the IGNA clinical practice recommendations that came out last year, also with ERKNet contribution, on children with steroid-resistant nephrotic syndrome. And there it is said that RAS inhibitors should be the first-line treatment for patients with steroid-resistant nephrotic syndrome. And so in our registry, we are following what percentage of patients with persisting proteinuria are indeed receiving these drugs, these medications. And you can see that this center is doing very well. 93%, 13 out of 14 patients are on this treatment, as compared to only 63% in the overall average of the ERKNet community. So again, you have a direct benchmarking here. Finally, we would like to proceed in the future with going mobile by designing a mobile app that will contain the most important information of the guidelines that we have developed or endorsed to facilitate the day-to-day application of guideline knowledge. Because oftentimes our colleagues do not have the time to go to their computers and look up guideline PDFs, but everybody has their cell phones in the jacket and can look up important information from the guidelines in an app. That's why we are now developing such an app to inform clinicians on the current best practice in a very compact and intuitive manner. And it also will contain interactive elements so they can go along the decision support algorithms that are given in many of the guideline documents. They can use them in an interactive way, you know, to the point where they are currently in the diagnostic or therapeutic management of their patients. And we plan to make this available free of charge for nephrology healthcare professionals worldwide, not only to the ERKNet members, of course.